Welcome to the EADV podcast. In today's episode, we are joined by Professor Michael Marks, who is the chair of the International Alliance for the Control of Scabies, as well as Professor of Medicine and Consultant in Infectious Diseases at the London School of Hygiene and Tropical Medicine. He has a particular research interest in neglected tropical diseases, STIs, Group A strep, and respiratory infections. He is joined today by researcher Romain Blaizot, medical doctor specialised in dermatology and infectious diseases, with a special interest in infectious and tropical dermatology. He is currently working in French Guiana at the Centre Hospitalier de Cayenne. But first,
we are excited to announce you can now register for this year's Congress hosted in Amsterdam and online from the 25th to the 28th of September 2024. The EADV Congress is one of the largest international meetings in Europe focused on dermatology and venereology, and the packed 4-day program covers the entire spectrum of specialties. This is an excellent opportunity for you to join delegates from all over the world and exchange knowledge, network with like-minded professionals, and develop your career. Find out more at eadv.org/congress.
Together they discuss a recently published paper on scabies and the challenges faced when treating scabies in patients from different territories and communities. Whether you are in Australia, South America, or Europe, there is a need for more data for a wider population where prevalence is different in order to develop appropriate control strategies for scabies in different settings. They cover what is driving treatment failures in scabies patients in French Guiana, adapting treatment programs to cultural settings, and the challenges of conducting effective follow-up treatment amongst remote communities. They conclude by discussing potential community-wide strategies for controlling the spread of skin health issues and fungal infections. Enjoy this practical and important conversation, and you can find a link to the paper referenced in our show notes below.
Well, welcome everybody to this edition of the EADV podcast. My name is Professor Michael Marks. I'm the current chair of the International Alliance for the Control of Scabies, and I'm joined by my colleague Romain Blaizot today, and we're going to be talking about scabies. Romain, maybe you could start by talking to the audience a little bit about the very interesting paper that you've recently published and how you came up with the idea and really sort of the work that you went about doing.
Okay, hello everyone. Hello, Michael. And I'm a dermatologist working in French Guiana in the Cayenne Hospital Center. And we just published, indeed, a paper on scabies and the particular challenges that we might face in treating scabies in this French territory. The idea we had was that there might be differences in the way you should treat scabies if you are working in Australia, if you're working in Europe or in South America, as we are today in French Guiana. And the idea was that there might be differences in the way you're going to treat scabies if your patient belongs to a specific community. For example, here we have many different communities, people of Creole culture, people of Native American culture, people of European culture. And the question we had was, should we treat them differently according to their means, according to the culture and the context they are living in? So what we did was to perform a study where we included all patients that we saw with scabies during more than 4 months in the summer across all French Guiana. Now, you have to bear in mind that this country is mostly covered by the Amazon rainforest, more than 95% of this country, and a large part of the people live in the hinterland, in the forest, and they have very few access to healthcare and to modern transportation. So we included 164 patients with scabies. We treated them as usual, and we saw them 6 weeks later. And we looked for clearance of their lesions, complete healing, or a failure. And we tried to find risk factors that could explain a failure in treatment. And we looked for not only medical, clinical factors, but also more cultural and social factors that could explain this failure.
Yeah, that's really interesting. I mean, sort of treatment failure for scabies is a I think, a hot topic everywhere in the world at the moment, and a lot of different things that we might consider to be causes of treatment failure. We can consider strict biomedical treatment failure, for example, resistance to the drug. We might consider sort of a halfway house. The drug is correct, but the patient does not put the treatment on correctly, or the remainder of the people that the individual lives with are not treated, and so there's reinfection. And then that the community that you're going back into is one where there is a high prevalence of scabies, and even if you treat the immediate family, for example, of a patient, they are at risk of reinfestation in the community. And one of the things I really liked in your study was this attempt to sort of tease out what is driving treatment failures, at least in this context of French Guiana. And my interpretation was that it was primarily not what we would think of as drug failure, but it reflected challenges people had in adhering to treatment, or the whole of the family or the whole of the community accessing treatment. And we know that if close contacts are not well treated, that there's a high risk of reinfestation.
Absolutely. And what we found out also, and it was quite unexpected, was that the patient would not take his treatment in the same way according to if you propose pills or if you propose a cream. It has been said in Australia, for example, that people were not comfortable when prescribed permethrin cream for scabies. And it is usually said that people would prefer pills for treatment or tablets. And what we found out, for example, is that Native American patients in our territory are very used to traditional medicine, where you would use topical treatment directly on your skin. And when they were prescribed topical treatment for scabies, they were usually much happier than when we prescribed pills or tablets. And the patient usually took that treatment much better in a topical way. So it's quite interesting, because it's something, when you have a European point of view, a European mind setting, this kind of findings that you may not be expecting, and can be very interesting. And it's an example. It's what we find here in French Guiana, but you may find something entirely different if you do the same study in another country, in another territory, with different cultures and different settings. So the idea, I think, is to do this kind of study in as many places as possible, to have really targeted and specific treatment guidelines for each setting.
Yeah, I agree. I think that's really critical. And you hit on the sort of key point, I think, or one of the key points, is that we must fit our treatment programs, our control programs, to the appropriate cultural context. Of course, we can have some broad overarching guidelines around the types of drugs we might use and the types of approaches, but what will be appropriate in one setting may be not the optimal strategy in another setting. And so that cultural awareness, I think, is really critical. Another strength of yours, which I'd be interested to hear a little bit about how you achieved, was I think it was valuable that you took people from the point of first presentation. Many of the reports of treatment failure focus only on the individuals who fail treatment and don't have good quality follow-up data on the people who have successful treatment. And that makes it quite difficult to ascertain how big a problem really is treatment failure. Because if you just describe 20 cases of treatment failure, that could be a big problem, or it could be tiny if you have treated 2,000 people. So I think that was a real strength of your study, and it was really just, can you describe a little bit about how you do follow up in this sort of setting where perhaps people are accessing traditional care as much as they are accessing, what we might think of as Western Ministry of Health provided care?
Yeah, of course. We had about 30% of failure, so it gives you an idea of how much the problem is important. And yes, you have to do. You have to be very active to reach out to these patients and make sure they come back 6 weeks later. They don't always have phone communication. Of course, transportation is very difficult. Many of these patients have to travel on small boats along the river to get to the health center. So coming back for a follow-up consultation is a kind of a challenge. And what you have to do is to use community workers, local health workers who know everyone in the village or in the neighboring villages, and ensure they're going to work with you on the study and give them a list of names of the people you need to see again in 6 weeks. And it will take them several days to reach out to these people. So you have to warn them a week before you come back to the village, if you want any chance to see your patients back. So it's a real challenge, and it's a good thing to do it for a study for several months, and it's even harder to keep this on the long way, on the long run, and to see patients on a regular basis after their first consultation. And you might always think that maybe if people don't come back, is probably because they did not experience failure, and they are well, and they don't see the point of coming back 6 weeks later.
Yeah. I mean, a lot of what you described sounds very familiar to me from other contexts where I've worked in West Africa or in the Pacific region. I wondered, taking your sort of learnings, what you think about how you might strengthen community responses to scabies in French Guiana. For example, would it be possible to not simply use the community health worker as a linking mechanism between the patient and the health system, but as a mechanism of actually identifying cases in the community and delivering some care in the community in order to reduce those barriers? I'm not sure, I guess, of the setup enough in French Guiana, but I wondered if taking your learnings, how you're thinking you might try and move forward scabies control in that context.
Yes, it would be a great idea, and it would be the most logical idea. Indeed, to use the local health workers to give them some training on scabies. And I think it would work actually quite well, because when I train them to include patients, I gave them some lessons, some lecture on scabies. I gave them some pictures that they could pass through the community to recruit patients, and it worked quite well. The problem is, and this is something that is quite specific to French Guiana, is that we are in South America in a very southern context, if I may speak so. But we are still working under the French legal system. And in the French legal system, it is almost impossible for someone beside a nurse or a doctor to perform such medical acts. And it's something that does not just exist in the French legislation. So we don't really have community health workers in the same way you may have in Africa. And it's something that you have to create in the French legislation before you can perform such medical acts with these workers.
I can see that's a real challenge for you in sort of delivering that. So I guess bearing those bits in mind, and assuming that we're not going to change the French legal system anytime soon, even for the rules in French Guiana, what are your thoughts about the next steps that would be deliverable in French Guiana? Is it improving the training of the staff at the healthcare posts so that when the research team are not there, they recognize easier? Is it developing more culturally appropriate educational materials for staff or for communities? What are the things that you think we can do to improve care for patients with scabies and other common dermatoses in this setting?
Yes, it's true. We need to have an integrated approach to treat all skin neglected tropical disease in the same time, including scabies. I think we should train more community health workers, even if they will not be allowed to give treatment to the patient, but so they might warn us as soon as they see something that need a dermatologist. And I think regarding scabies, we should work on the disinfection of on the environment, which we found out to be very difficult for our patients, and to provide them with some free solutions so they might clean their clothes and bed sheets and hammocks and everything, which can be organized in a very easy way with not so much money after all. And I think it would be a good step forward.
That's an interesting proposal. I think that remains quite controversial, I guess, within the scabies community, the extent to which environmental measures are that valuable. For example, when we have done work in the Pacific region, where let's say 20% of the population have scabies, we've found that treatment of the whole community alone is really sufficient without worrying about environmental measures. And I think always the difficulty is disentangling, does treatment fail because the clothes or the bedding or the hammock is not disentangled, or because everyone else in your household has scabies, or the children you are still at school with, they still have scabies. I wondered if you had considered any whole community-wide interventions. Again, I'm not aware how acceptable those would be within the French legal framework, but I would think in other contexts where the prevalence of scabies was very high, 10, 15% in the community, a strategy that has proven quite successful is simultaneous treatment of the whole community. Is that something that could be done in French Guiana, or that you have considered?
Yes, it's something that could be done, and we have considered it. But it's true that the prevalences are a bit lower, about 4-5% maybe. So we do not really reach the 10% threshold that is usually advised to start such interventions. But it's something that could be done, particularly in small settlements that are really remote and isolated, and that everyone in the community will be here on a given day, and you can treat everyone in a few days. So it's something that we are working on, but it's possible under the French legal system. But it's true, it's not something that is usually done in this country. So we need a bit of experience, but it's something that we are considering indeed.
Yeah, I think the scabies community at large would be very interested in that work. Without telling you, of course, what you should do next, I was involved in setting the 10% threshold, and we didn't, I think it's fair to say, set the 10% threshold because there's something magical about the number 10%. It was set because most of the studies that have been done at prevalences of 10% or above. And in fact, the WHO guidance document says that really between, say, 2% and 10% is a real grey area where there is a strong need for evidence about whether or not it's best to deliver community-wide strategies or strategies delivered through the routine health system. And I think what you're describing, there's certainly possibilities to explore that a little bit more. Maybe just whilst we were talking about scabies, because we did touch on other dermatoses, how much, when training your staff around scabies, how much have you trained them to recognize other skin conditions such that scabies becomes a sort of portal of entry for thinking about broader skin health issues?
Well, I must say maybe not as much as I should have done, but it's true. It's the next step. I think is to use scabies indeed as a portal of entry, and to train these health workers and the nurses and the doctors on the field for every dermatosis that we might find here. We have leprosy, we still have cutaneous leishmaniasis and Burley ulcer. So we should train them for all of them. But it's a matter of energy and time. So it's not something that I could do until now, but indeed it will be the next step. So we may have an integrated approach. And it's true that when you have a dermatologist who travels so deep in the rainforest to a small settlement, it's a good thing to use this mission and to treat all dermatoses at the same time and not to focus only on scabies, of course.
Yeah, I definitely agree. But an advantage scabies has is that it's quite common. Cutaneous leishmaniasis, Burley ulcer, leprosy are obviously significant causes of morbidity, but even in settings where they are relatively common, they remain rare diagnoses compared to scabies, impetigo, fungal infections. Well, Romain, it's been really interesting hearing about the work that you've been doing in Ghana, and we hope to hear more about it in future papers, and really look forward to seeing what the next steps in your journey there are. We desperately need more data from a wider range of parts of the world where the cultural contexts are different, where the prevalences are different, so that we can understand how to develop appropriate control strategies for scabies in different settings.
Thank you very much, Michael. It's been a pleasure.
Before you go, a quick favour. If you are a regular listener to our podcast, we would love to hear from you. Your feedback will help us improve the show and develop episodes that you are interested in hearing. To participate in the short survey, simply follow the link in the show notes of this episode. Thank you for your support, it means a lot. We look forward to hearing from you. Until the next episode, take care of your skin.